Thank you.
So we have the next speaker, Dr. Aditya Anand. He will be talking on macular function tests in opaque media. So he has done his DNB from Arvind Eye Hospital, Pondicherry. He's a fresh, young, knowledgeable person, and he'll take us through the macular function tests in opaque media. This is a very interesting topic.
Good afternoon, everyone. I will be dealing with macular function tests in opaque media.
From mic,
Yeah.
keep your mic near you.
Hello. Yeah. I'll be dealing with macular function tests in opaque media. So whatever we will give a general background of what is anatomical background of macula is a round area at a posterior pole temporal to the optic disc, which is 5.5 mm diameter. It comprises of fovea centralis, foveola, and foveolar vascular zone. And those are specific anatomic configuration of the fovea has the densest concentration of cones, a 1-to-1 photoreceptor ganglion cell relationship, cones more elongated and slender, its absence of rods at the foveola. RP cells are taller, thinner, and deeply pigmented, and presence of xanthophyll pigments. It gives a highest discriminative ability or color perception. So why we should look at the macula? So it has a clinically compelling situation such as vision which is not improve after cataract surgery, after refraction, referred cases with unexplained vision loss, children with strabismus, and the pointing symptoms such as inability to read fine prints, metamorphopsia, minification, magnification, obstruction, positive or negative scotomas, or color vision changes. So basically we have to do this macular function test to look at those symptoms. So MFT macular function test with either can be done in the clear media as well as with the hazy media. So here I will be discussing about only the opaque media. So just we'll go through like what are the MFT with clear media: visual acuity, contrast sensitivity, slit lamp biomicroscopy, photo stress test, color vision, Amsler grid, microperimetry, FFA, and OCT. And opaque media, the MFT tests are the Maddox rod test, focal ERG, VEP, laser interferometry, potential visual acuity meter test, and toptic phenomena, preferential hyperacuity meter perimeter, and B scan. So one by one we'll just go through the important points of each test. So Maddox rod test, here the patient is asked to fixate light either at a distance of 33 centimeter, which is a near distance, or a far distance of 6 meter through Maddox rod with opposite eye occluded, and it converts the point source of light to a line that is seen by the patient. The Maddox rod is rotated vertical, horizontal, and oblique, and the patient is asked what direction the line is oriented and whether the line is continuous or not. So any breaks or hole, discoloration, distortion indicates a macular lesion. So the responses of Maddox rod test are noted as the 4 graded response. So grade 1 response will be like a patient can identify the direction correctly in all 3 positions. The line appears straight, continuous, correct in color in all 3 positions, which indicates 6/6 or 6/9 vision. Grade 2 response, the patient can identify the direction correctly in all 3 positions, but line appears straight but broken and correct in color in all 3 positions. And grade 3 response, it identifies the direction color but is unsure whether the line is straight or not. And grade 4 response, the patient can correctly identify only color. So focal ERG, here ERG is only abnormal when a large area of retina is functionally impaired. So it's a record of changes in the eye's resting potential caused by a flash of light. It's a summation of the action potential of the retina and is used to record the integrity of the rods and cones, bipolar cells, and retinal pigment epithelial cells. So ERG procedure, I'll just go through fast here. So there are 3 electrodes which we use here: active electrode, reference electrode, and ground electrode. So active electrodes are put either in the corneal either as corneal contact lens, Goldwick electrodes in the conjunctival sac, or gold foil electrodes on the eyelids. Reference electrodes will be placed at the lateral canthus, ground electrode placed at the nasal canthus, and a Gansfeld stimulus is used to stimulate the retina, and the changes in the resting potential are recorded as a graph. So first, scotopic ERG is first performed after pupil dilatation and after dark adaptation for 20 minutes, and increasing intensities of the stimulus are presented to the retina, and recordings obtained are referred to as a dark adapted ERG. In a photopic ERG is performed after 10 minutes of light adaptation, and increasing intensities are presented to the retina, and light adapted ERGs are recorded. And there are the 3 types of ERG: full field ERG, pattern ERG, and multifocal ERG. So ERG is recorded as shown in the graph. So here the A wave is a small negative wave that originates from the photoreceptors, B wave is a large positive wave that originates from the bipolar cells, and C wave is a slow rising positive wave originating from the RPE cells. And here there are three terms which we should know: amplitude, implicit time, and latency. Amplitude is a maximum of the measure of the maximum deviation. Implicit time is a time interval between the onset of the stimulus and the maximum response of either A wave or B wave. Latency, the time interval between the onset of the stimulus and the start of the wave. Next, we come on to critical flicker fusion frequency. It is defined as the frequency at which the flickering light can be perceived as continuous. It is used to access the processing of temporal vision, and critical fusion flicker fusion threshold, which denotes the fastest rate of flickering light that the visual system can see, and is used to characterize visual processing. And during the critical flicker frequency test, the patient is asked to fixate on a light emitting diode that emit light and that oscillates at a gradual increasing frequency, and patient is asked to press a button when they believe the light to be continuous. So this is reduced in retinal and neural diseases, but resistant to degradation due to media opacities. This is how it is recorded. Here the flicker sensitivity curve is plotted for a given point on retina as a function of flicker frequency, and a minimum modulation depth at which the test spot is barely perceived to be flickering is defined as a threshold modulation, and this is what we measure, which is the reciprocal of which is called sensitivity. Dark adaptation, it's a done by Goldman-Vickers adaptometer. Normally the whole process of dark adaptation requires 15 to 30 minutes. And here the subject is exposed to intense light that bleaches photoreceptors, then suddenly placed in dark, and the flashes are repeated at regular intervals, and sensitivity of eye to light is gradually increased, and we get the reading as a curve. So this is the dark adaptation curve, in which we can see the cones are more sensitive in the starting, then rod cone break happens, and then rods are more sensitive, and gradually it remains for a longer time. The clinical applications of this are the disorders of pigment degeneration, neural adaptation, chloroquine toxicity, retinitis pigmentosa, high myopia, glaucoma, and retinal degeneration. VEP is also an electric potential generated in response to visual stimulus. Here the macula has the largest representation within the visual cortex, so VEP produces a macular dominated response. So here done in two ways. In the two systems of placement of electrodes are there, 1020 international system and Queen square system, and it is of two different types of VEP: flash VEP and pattern VEP. So flash VEP is presented to the eye at a rate of 1 to 5 times, and it indicates if the stimulus was perceived by the cortex or not. It's test of choice of infants, and it can be done during sleep. And pattern VEP, it roughly estimates the visual acuity and a checkerboard pattern. So we should remember the three waves here. Positive waves are P100 wave, and negative are N75 and 135 waves. Here, if the largest amplitude fastest waves are produced with a checkerboard stimulus with 5 to 6 mm squares, the visual acuity can be estimated to be around 20/20. But if the largest amplitude fastest waves are produced within larger checkerboard stimuli, the visual acuity is correspondingly lower. Laser interferometry, here we produce the interference stripes of fringes that are projected onto the retina. Beam produces 2-point sources behind the lens opacities. So here it is able to predict acuity up to 20/20. I'll just take one more minute. Yeah. So a spatial frequency of 30 per degree is equal to 20/20, 6/6 visual acuity. The different models available are Heinz lambda retinometer or Lotmar visometer, and advantages of this are unaffected by the optics of the eye, and it is more accurate than potential acuity meter. Here the patient pupil is dilated. The interferometer is used to project a fringe pattern onto the retina. The patient is asked to recognize the direction of the fringes, vertical, horizontal, or oblique, and the fringes are made finer until the patient is unable to identify the orientation, and the endpoint fringe pitch is noted and correlated to the Snellen's visual acuity using a chart provided. The limitations are in the tilted retinal receptors or healthy photoreceptors in CME, it gives a false positive test, and false negative in a very severe dense cataract, dense VH, or poor pupillary dilatation, false negative test. This is again a device PAM. It is used in predicting the post-operative visual outcome after cataract surgery in patient with retinal pathologies like dry ARMD and those with choroidal neovascularization, and it can also be used to predict vision after ND-YAG capsulotomy in patients with posterior capsular opacities. Here we can see that inverted Snellen's acuity chart is projected onto the retina, and the smallest Snellen line where the patient can read 3 or more characters is recorded as the potential acuity. And there are 3 antoptic phenomena, Purkinje vascular antoptic phenomena, flying spot, and Heidinger brushes. The vascular phenomena, it elicited by the response by placing a pen light against a closed eyelid or the globe and moving it back and forth and creating images of the patient retinal vascular tree. Flying spots, these are the movement by the leukocytes, and it is in a curved sinusoidal patterns and takes the stimulate the capillary loops of the vascular tree. Here the point to be noted, if the intraocular pressure is above 50 mmHg, the moving ceases and then we can't see the flying spots. And the background illuminated by the blue light in spectral region of 350 to 450 nanometer. And coming on to the last, Heidinger brushes is a phenomena caused by variation in absorption of plane polarized light by oriented molecules of xanthophyll pigment in the foveal retina, and is used to sensitize the fovea in amblyopic child with eccentric fixation. And hourglass shaped yellowish brush is seen radiating from the point of fixation, and rotating polarizes the brushes also rotates. So if the patient can perceive shadows of the arborizing retinal vasculature, the macular function is probably normal. If they cannot perceive the vasculature, macular function is probably poor. Similarly, in the blue field antoptic phenomena, if there is a partial loss in movement, a complete loss, or slow movement, the retinal function is abnormal. Okay.
Aditya, can you sum up? Because
okay, I'll just go sum up the important.
I mean, what are the important tips that you want to give, especially for patients who have got corneal opacity?
Okay, I'll just okay. So if there is an opaque media or a severe dense cataract, or
what are the tests that will advocate to the ophthalmologist?
Basically,
because we do not have all the gadgets.
Yes, sir. So basically, we go through we generally perform ERG or VEP tests, or in a very semi-opaque media, we use a Maddox rod test.
The first test that you said, that is more practical, the Maddox rod test.
Yes,
gives you.
Yes, but that can be used always. It's even in the very severe dense cataract, dense posterior segment pathology, we can't use that also. But in a semi-opaque media, we can definitely go ahead with that.
Then the second test is the ERG, which is specific.
Yes, ERG and VEP. And since the time is up, so we can't discuss the other. There are a lot of tests which are recently also, a lot of new innovations are coming on this.
Okay, thank you so much.